Hello, my name is Jorge Cortes from the Department of Leukemia at MD Anderson Cancer Center in Houston. Welcome to Medscape Oncology Insights, coming to you from the 2017 American Society of Hematology annual meeting in Atlanta, Georgia. Today we will be discussing some of the highlights of the leukemia sessions at this meeting. And joining me today is my friend and my colleague Dan DeAngelo, Director of the Clinical and Translational Research in Adult Leukemia Program at the Dana-Farber Cancer Center. Welcome, Dan.
Thank you. Thank you, Jorge.
So, Dan, why don't we start talking about some of the abstracts? And you had a fascinating, very prominent plenary session, new study. So tell us a little bit about that.
Yeah, so BLU 285 is a novel KIT inhibitor. So systemic mastocytosis is a disease that's driven predominantly by KIT mutations. In fact, 90% of patients with systemic mastocytosis, not a common disease by no means, will have a KIT D816V mutation as their driver. And this particular molecule, the BLU 285, binds to KIT in the active conformation, number one, and number two, it's more potent at inhibiting the mutation, the KIT mutant form, as opposed to the wild type. So it really lends itself to a very optimal toxicity efficacy ratio. And we were able to show in our phase 1 study that almost 100% of the patients had disease control, wow, and 72% of the patients had a response, with 56% complete and partial remissions. So we were very excited, and no patient came off study because of toxicity concerns. Wow. Rather unusual in the phase 1. Yeah. So very exciting.
Excellent. So where is that going now?
Well, so over the last couple years, midostaurin has been in clinical trial development, and it was just approved by the FDA this summer for patients with aggressive systemic mastocytosis. So I think for the first time, hematology oncologists are learning about the disease, how best to handle the disease, because historically these patients would come through dermatology, would come through allergy immunology, and land on the doorsteps of the hematologist. But now we actually have a therapy, right, and now we may have even a better hammer, if you will, to drive home the patient. One of the most profound observations with this particular study was 60% of patients actually, in the short period of time that they were on the study, 60% of patients achieved a complete remission. So marrow remission, that is. And so we're very excited with the outcome. And moving forward, I think it should be tested in, to formalize the data in a phase 2, but also in earlier stages. What about indolent systemic mastocytosis, smoldering mastocytosis? And I think this is it's an unmet need, number one. And number two, I think there's a lot of education. We had a separate abstract as a poster where we looked retrospectively at patients who had been molecularly profiled and had a KIT mutation. And not surprising, every single one of those, even though they hadn't been diagnosed, when we went back and pulled the marrow, every single one of them had systemic mastocytosis, wow, that the pathologist had missed. Yeah. So an education.
Very interesting, very good. Well, you mentioned midostaurin, and of course we recently had the approval of midostaurin in mastocytosis, but also in AML.
Yes.
And we've known midostaurin for a while. It had some activity as a single agent, as a FLT3 inhibitor. And we recently had it approved in combination with chemotherapy for frontline FLT3 mutated AML. And one of the things that's been a little bit controversial was the issue, the study had the design of going through maintenance, but not too many patients got the maintenance, so it's actually not in the label in the US, it is in Europe. So there was a very interesting abstract presented here by Dave Larson about whether there is indeed a benefit or not with the maintenance. What's your take? What's your take on the abstract, and what do you think?
So this is one of those regulatory issues, right? So as you mentioned, the ratified trial, which enrolled patients between 18 and 60 with newly diagnosed untreated FLT3 positive, both ITD as well as the second tyrosine kinase mutation, mostly D835. They got combination chemo plus the midostaurin. And then the way the study was designed is that if they did not go to transplant, they would get maintenance midostaurin. The world changed when the study was written, and more patients were moved to transplant. And so there was a large percentage of patients who just went directly to transplant and didn't receive midostaurin. And midostaurin was not tested in the maintenance session of the study in a randomized fashion. So they didn't get an indication through the FDA through a regulatory, in my opinion, more of a regulatory issue. At our center, and a patient goes to transplant, we usually put them post-transplant on a tyrosine kinase FLT3 inhibitor. We have phase 2 data at our institution looking at sorafenib, a different drug that improves survival after transplant, and I think midostaurin, given its indication, is a very reasonable option. And as you already mentioned, the European regulatory agency approved it with it in its label. And so you get this conundrum about what is the way the study was designed, what the different regulators want, and what we as clinicians should do. I believe the data suggests that maintenance therapy is beneficial. I think this is a difficult disease, and anything we can do to ameliorate relapse makes sense to me.
I agree, and I mean, looking at the data that was presented, it was interesting. I mean, the maintenance went for a year, as you mentioned, and then so that for that 1 year, the curves separate a little bit at the beginning, and then they merge back again. Right. But then what was interesting is that he presented another curve after that 1 year, and it looks like there's a lot of relapses that happen as soon as they stop the maintenance, and then it plateaus. So you know, of course, it's an extrapolation, but you wonder, I mean, did they relapse because we stopped the maintenance and they were really having benefits? So, you know, it's a difficult, and with all these design issues and whatever, we don't have an answer, but I get the same feeling as you, that there is benefit, at least for some patients, for a subset of patients, and we typically continue these maintenance after transplant.
I mean, the theme has emerged since TKI therapies were introduced in chronic myeloid leukemias, and you know, when do you stop? Well, you know, rarely in that disease, maybe it's a bad example, of that disease patients do get into complete remission, but in absence of that, we continue. What happens if a Philadelphia positive ALL patient goes to transplant? You know, those patients on the SWOG study, led by your colleague, Dr. Ravandi, they continued after that. Why wouldn't it be the same in this disease? It's as malignant as anything, and so anything I think you can do to mitigate relapse is important. And from a biologic perspective, you know, it's post-transplant or post-therapy, is unless we know that you're getting patients into complete molecular remission, and we didn't test that on the Ratify study, you know, then there may be low-volume disease, and continuing the inhibitor should benefit the patient, and that's my interpretation from Dick's study.
I agree. I feel the same way. And speaking about maintenance, there was another very interesting abstract that came from the Hovan study. This study where they gave patients the standard chemotherapy and consolidation, and then they randomized them to go to maintenance with azacitidine versus observation, which is kind of the standard now when we finish the chemotherapy. And they showed a very significant separation of the curves on the disease-free survival, and you know, those curves look very good. So, you know, what's your take? You have experience with a similar trial.
Yeah, so maintenance chemotherapy following treatment for acute myeloid leukemia has been tested for the last decade and a half. It's hard to do these studies, and the reason is because patients become fatigued. Patient fatigue is what I consider it. In other words, you get a patient through induction, you lose some patients along the way, then they get consolidation, and at the end of this painful, long, toxic therapy, then you offer the patient more chemotherapy. And the patient says, what? So it's been a little difficult to do those studies. We've done 3 maintenance studies within the cooperative groups, and they've all shown a trend, but not a statistical benefit. But I think the limitation with those studies was the fall-off. There were so many patients who declined to be randomized, or once randomized decided, yeah, you know, it's not for me. And the difference in the Hovan study was many more patients agreed to randomization, many more patients stayed with the randomization. I think the choice of maintenance using azacitidine instead of maybe decitabine, which is a little bit more myelosuppressive, was a right choice. And I think the data is provocative. But the devil's always in the details in terms of who benefits. So were the patients who benefited those patients who had evidence of clonal hematopoiesis, for example, abnormal molecular findings? Did they have a molecular profile going into the therapy that was more suggestive of an underlying secondary AML? You know, our group has looked at the ontogeny of AML. Just because a person walks in the door with newly diagnosed AML, there are sometimes signs of earlier disease, and maybe those are the patients that benefited. So it'd be nice to know which patients benefited. If possible, we can learn from that. But I think it provides us another intriguing option.
Yeah, I think so. And you know, we've done a study with the cytarabine, similar randomized. Ours didn't show much, but as you mentioned, you know, there's all these details, but this data, I think, opens new avenues. We do it a lot after transplant, for example, azacitidine, so I don't think that we should say everybody should get maintenance with azacitidine right now, but I don't think it's dead either. I think we need to do a little bit more.
I think this opens up the box, and I think the important thing about the HOVON study was that the toxicity was rather minimal.
Yeah, exactly. So. Now, speaking about, we talked about midostaurin. Another drug that was recently approved was the IDH inhibitor. And we have a few abstracts here that provide some follow-up data and some new information. So let me start with one that was kind of a follow-up, or just showing how the responses can happen very late, and it was shown that you know, initial responses can take 4, 5, 6 cycles sometimes. So, and I think that's important because, you know, now we're using this drug, and probably at the beginning when we started the phase 1 study, we missed some possible responders because we didn't recognize this differentiation syndrome and all of that. So what do you think about that?
Oh, absolutely. I mean, I'm intrigued by this drug. You know, the overall response rate, 30+%, is exciting, but I agree with you. I think there may have been more responses had we really know what we're doing. I think the eagerness to take patients off study early on, hindsight's always 20/20, of course, was unfortunate. In my own clinical experience, I've seen patients go into remission after 4 or 5 cycles. I remember a patient who had relapsed after stem cell transplant with an IDH2 mutation and went on therapy, and it was 3 cycles before we really started seeing a reduction in his blast count. And then he went into complete remission, transfusion independent, for more than 2 years. I mean, with taking 1 pill a day. I mean, how great is that? And you could have easily, if I had had other options, I don't mean, now I know, you know, you could easily see how another physician not treating the patient on clinical trial and not knowing that would have been too eager to take the patient off. You know, after 1 month, no response, after 2 months, no response, after 3, but the patient wasn't progressing.
Right.
And then eventually he responded. So I think that's a very important point. I think that's a profound point. And recognition of the differentiation syndrome is also somewhat important, and that came out in this abstract as well as in the publications, of course, is just recognizing when you start seeing these leukocytosis, it's not always disease progression, especially if people are having cytokine release, you know, with some low-grade fevers, shortness of breath, capillary leak. It's reminiscent of ATRA or APL differentiation syndrome. You know, the agent is what it does. It deletes the IDH2 clone, and for patients who have limited options, it's really a wonderful tool in our handle.
Yeah, and the drug is approved, of course, and it was approved for the relapsed refractory patients. But there are some other very interesting studies here. One is where they analyzed, the study did allow patients that were previously untreated. So they analyzed a subset of patients that were previously untreated that went to that study, reporting the response rate. And it's somewhat modest. The CR rate, I think it's in the teens, 18, 19%, something like that. And the overall response rate, 30-something%, similar to the refractory relapse, interestingly enough. So then there's a couple of studies looking at frontline therapy in combination with other agents. There's one with azacitidine, another one with the standard 3+7 type chemotherapy. And the results are early, so I don't know that the response rate that we see is what we're going to see. We have to see more data. But what do you think about that concept, you know, as initial therapy, alone, combination?
Well, you know, the fantasy that we have, at least I have, is that you take a patient with AML, you molecularly profile them, they have mutation X, so you get inhibitor X. They have mutation Y, you get inhibitor Y. And we have more tools in our belt. We have midostaurin for patients with FLT3 mutations. We now have enasidenib for patients with IDH2 mutations, with IDH1 and others not far down the road. The BLU or midostaurin maybe for KIT inhibitors, for KIT mutations, I'm sorry. So, I mean, if you live a fantasy, I think that's the way it should go. The problem is improving it.
Right.
Because these are rare diseases. So you have, if you take the Ratify trial where you're looking at one of the more common targeted mutations, 25% of AML has an FLT3 mutation, either ITD or D835. IDH2 at most 15%, IDH1 maybe 7, 8%. So it becomes a little bit more difficult from a and then we get back to the regulatory agencies. How are they going to prove it? Are we going to need randomized trials for these rare mutations? That's my take, but it's nice to see these trials starting to accrue patients and starting to really show that it's safe. And I think with time we'll learn about some of the efficacy signals. Yeah. But I worry about the regulatory approach for these, and I'd hate to, be perfect, the evil of good. I'd like to have these options for our patients.
Yeah, I agree. It'll be interesting to see, as you said, as the data matures, because with the FLT3, those patients have a very poor prognosis. With the IDH, it's not that bad. It just, so we have these drugs. So is the chemotherapy needed? Are we going to? Maybe what will help us is to debulk, and then you have to do less consolidation and just go
or maintenance
or something like
maybe
that.
It's a lot of different options. Of course, when you say the IDH1 and 2 mutations, the prognosis isn't so bad. It depends on your glass half full, glass half empty. Of course, when you look at a 35-year-old patient in the face and say, well, it's not a bad prognosis, but you have a 50% chance of survival. I mean, to me, that's still not so great.
That's not great.
The only leukemia is no leukemia. So I think anything we can do to improve the outcomes would be a benefit.
Let me very briefly go to just one last thing. And venetoclax, of course, we know about this great benefit in CLL, but there's been a lot of interest in AML. There's been single agent data and then some combinations. And let's just talk briefly, for example, about the Andrew Wake is showing an update on his study with low-dose RSC in combination with venetoclax, and there's been also the studies with hypomethylating agents, and the responses look remarkably good. Yeah. So how do you see?
Well, I think the big problem with leukemia is the fact that our chemotherapy is okay, which you had mentioned, and the problem is that patients just are not eradicating their disease. So anything we can do to improve or increase the apoptotic rate, that is the programmed cell death, is going to help our patients. And chemotherapy works through this apoptotic pathway, and venetoclax is the natural drug to try and augment that process. And this is an example where the drug as a single agent works, but it has a CR rate of about 20%. But with chemotherapy, as you mentioned, even low-dose chemotherapy, which by itself has a minuscule response rate, the two together are synergistic, and you're seeing these response rates into the 70%. The key thing is to really learn how to safely administer it. But I don't know about you, but I haven't seen responses with lower dose, if you will, chemotherapy that this high ever. Yeah. So I'm fascinated by it, and I think, how do we use venetoclax not just with low-dose chemotherapy like low-dose RSC from Andrew Way or hypomethylating agents as Dan Pollier is presenting at ASH, but what about other chemotherapy backbones? I think I know you and I, or at least your center and I, have a study now starting adding venetoclax plus chemotherapy for ALL. Yeah. And so I think we need to take a look at it. I don't know it's a one-size-fits-all thing, but these two abstracts are very provocative and really showing the proof of principle. Yeah,
absolutely. Well, this is a great discussion, Dan, but we need to close. Thank you very much for joining us, and thank you for the discussion. And thank you all for joining us in this discussion. My name again is Jorge Cortes from the ASH 2017 meeting in Atlanta, Georgia.